No more than
Okay.
3 months, ma'am.
Hi, Rishi. So welcome to the group again. Rishi was just telling me that I have to be on my best behavior, but I think it's Mr. Singhal that needs to be on his best behavior. So he's been working from home doing lots of research today. So hi, Rishi. It's great to have you back. And I have to say, I've got all my technology here because we've got lots of questions, and I've just seen some more questions come into the group. So how are you doing? Are you all ready?
Looking forward to it, actually, Van. I think the entire day I was doing a lot of research, as you alluded, and I think our patients will be pleased to know, and I would be quite happy to share some of the research with the patients as well. Just 3 months ago, we published the largest data on bariatric surgery in the world from Birmingham,
right,
which showed actually doing bariatric surgery during COVID is quite safe.
Fantastic news.
The risk of COVID was quite low, and nobody was seriously unwell in this data of 2,000 patients from the world. Only 10 patients contracted COVID and nobody was unwell. So I think the basic message to the world, although these are difficult times, I think surgery is soldiering on, and we have the protocols in place so that we can perform surgery safely as long as we can.
Right, that's fantastic news. And I know that when patients go in, that they have to be tested to make sure, they have to isolate, and once again they isolate when they're at home, so it's pretty safe, which is great to know that you've actually got the statistics for that. So fantastic. Well, I'm going to kick off with one of my questions, as I always do. So, and this is because a lot of patients ask me this, and I know the answer, but I think sometimes it's good to reaffirm it from you. But patients whenever I'm speaking to patients and doing my discovery calls to find out what support my clients want, the number one question I get with patients that have had surgery and they're 18 months out and they're regaining weight, or even 12 months out, is, can I stretch my sleeve? And that is one of the questions that one of the patients in the group has said, can I stretch my sleeve? And if I can, would a pouch reset diet work? Now I know the answer, but I think it'll sound really good if it comes from you, because I think sometimes they don't believe me when I say, I'm not even going to say what I'm going to say, but I'll let you say, what do you think of pouch resets? And also the other question was, how much does a gastric sleeve and a gastric bypass pouch hold in terms of volume?
Right. So let's start with the first question first. Bariatric surgery is not just about how slim the sleeve is, it's also the hormonal effects of the sleeve. So the answer to your question, that can you stretch a sleeve? The answer is yes. The second question, will a pouch reset help? I don't think so. It won't shrink the size of the sleeve again. But the sleeve effects are due to the hormonal mechanism as well. But we need to understand one thing. Bariatric surgery, and correct me, Van, if I'm wrong, bariatric surgery is a way to let you learn good habits during the honeymoon phase, which is 2-3 years of bariatric surgery.
Absolutely, and that's exactly what I say.
And that's the time that you have bought with an operation to learn good habits. But if you do not learn good habits, no matter which operation is it, whether it's stretching the pouch, stretching the sleeve, or gut adaptation, which is what we think now is actually happening in all patients, gut adaptation, that your gut just stops, it takes on the role of the stomach and starts absorbing more food automatically. So I think the important thing we have to understand is that surgery is not for life. There's a period when it works very well, and you have that grace period to learn good habits and to maintain them. And if you don't do that by the end of 3-4 years, 5 years, you will eventually end up gaining weight no matter which operation you have.
Completely agree. I agree. And I always say to my clients when they're on a discovery call, the first 6 months, and maybe even shorter than that, first 6 months is the real tight honeymoon period where the sleeve and the bypass does feel, they're really getting the full effect from it. So that's the time when they're motivated, they're focused, they want to make the changes. That's the time to get in there and really, do the mindset work, learn how to work with your surgery, understand how it works, the hormonal effects. But also what's really important is to make everyone aware of what will come in the future if you don't maintain these changes. Now, I know a lot of it is this black and white thinking. And at the moment I'm doing, in this membership, I'm asking everybody to set goals. And I'm going to be talking to them on Wednesday evening, but a lot of their goals are quite unrealistic. They want that rapid weight loss, like as if they've been on a fad diet. And they have this black and white thinking of it's either working or it isn't. And I think trying to break that down, that mindset, is really difficult at times, especially if they don't get the right support. And I think that's one of the reasons why maybe in 6 months' time or 12 months' time or 15 months or 2-3 years, all of a sudden it seems like the surgery isn't working. But also, we have to make sure, how well are you working with the surgery? Have you lost touch with all the things that you've learned because it was too much? You felt overwhelmed with all the changes, and now all of a sudden, week by week, all these old bad habits are creeping back in. And this is why long-term support, I think, is essential for this group of patients. And it's something that I know that I'm working on. But I think you're right. Yes, patches can stretch if you abuse them. But how much does a sleeve hold?
It's variable. It depends on the size of the stomach that you were born with. It is very, very, very difficult. I think
I usually say between about 4 and 6 ounces, which is about 100 grams to about 150 max, that sort of range. But it depends on the bougie that you use as well. Is that correct?
Right. The problem is that every bougie size is different.
Yeah.
So it is easier to calculate how much stomach is removed.
Right.
And how much stomach is left in. There is no easy way to calculate that. So in a bypass, you would say it is around, the size of the pouch is around 5 centimeters by 2 centimeters. So you can multiply it, but the sleeve is very variable. But I don't get bogged down with that at all. I don't think that is important. If you're a tall guy, you'll have a tall stomach and you'll have a longer sleeve and more volume.
Yeah.
But it's still similarly restrictive.
No, absolutely. And it's just a question that lots of patients always ask, and I give that sort of guide. It's going to be around 4 to 6 ounces, but again, it differs, and the hormonal effect will make it feel different. And soon after surgery, there's a lot of swelling, so it will feel a lot tighter than that. It might be that you can only manage 2 tablespoons of food. So, okay, right. The next question is from Caroline. She had a gastric band fitted in 2008, which was removed in 2015. She had lots of post-operative complications, which resulted in a 5-week hospital admission. Not sure what the complications were. Her weight now is the same as it was pre-band, and she's thinking of a bypass. So she's thinking about revisional surgery, but she's absolutely petrified. And I've spoken to Caroline myself. She's really scared of the post-op complications. She's also a nurse, so she's probably got a lot of inside knowledge as well. And she's constantly asking everybody whether or not she should do it. She says that she can lose the weight, but can't keep the weight off. She feels tired all the time, no energy. She's got no health conditions apart from a dodgy right knee. She's got a bit of shortness of breath. Her BMI is 40. She's age 51. I know what my advice would be. What's your advice? What should she go for it?
It's very simple. The fear of revisional surgery comes, and I'll be a bit opinionated here, as I'm usually. It comes from the fact that a lot of surgeons do revisional surgery, but they don't always, they're not experts in revision surgery. So there are some surgeons in UK who mainly do revisional surgery.
Can I just stop you there? Just to let everybody know, Rishi is the king of revisional surgery. So if you want revisional surgery, he's the one to go to. Go on, carry on.
There are 2 or 3 surgeons who do a lot of revisional surgery in UK. If you go to them, I don't think you will ever have a complication. I mean, the risk of complication with a band to bypass in my hands is exactly the same as a bypass.
Right.
So whether I do primary or revisional bypass, the complication rate in my hand is the same, which is less than 1 in 100.
Right.
So it's very rare. The last time I had a leak in a revision bypass was 5 years ago, and that was my 3rd bypass ever. And since then, I've never had a leak in my career. I've only had one. And I know the patient could be listening. So I've only had one ever in my career. It is very rare, but you need to go to surgeons who do revisional surgery, and it is safe. Yes, any surgery can go wrong, but then you need to know the surgeon that you are with can handle anything. So it's a question of you understanding your surgeon and meeting them. But at the same time, if you're going to have revisional surgery and you've already had one operation in the past, you need to have a support network around you. You need to have support, not immediately at 6 months, but maybe 1 year, 2 years, 3 years, 5 years after surgery. Because after a band to bypass, I think there are no options left. So Yes, you should do it. And yes, you should plan it out in such a way that you have enough support so that you are armed with a tool for the rest of your life.
Yeah, completely. And she says that she should give it a go one last try. I mean, she means by dieting. And I think, Caroline, I think deep down, I think you know what you need to do. You need some support before surgery. You get the surgery done, and then you get lots of support after surgery to talk you through it. Because I find with revisional patients, they expect a lot more. But with revisional patients, you may not get as good as results the first time round. But I think that depends on your preparation. And if you're aware that you've got to work with this new tool, it works completely different to the band, I think you can really work it. So I think it's all about mindset, your determination, and understanding how this weight loss surgery tool works. What do you think, Rishi?
No, I'm absolutely with you on that. I mean, every revisional patient that I do is consulted by Van. So I do not do any revision surgery unless Van has seen the patient. And I think that is very, very important because the revisional patients are having a second chance and some of them are having the last chance. And most band to bypass are last chances.
Yeah.
So you want to do it in a very well prepared way with a team that you like, with a team that you can support you and have mechanisms around you that will support you to maintain this weight loss.
Yeah, and it's all, and the thing that I'm looking out for is emotional eating, that mindset. You know, if you haven't got that under control, it's, you know, you need to, because no surgery can fix the emotional aspect of eating. Now,
No.
Caroline's also got in another question here. She says, what if you suffer from IBS or diverticulitis? Will this affect having a bypass? So that's her revisional surgery. Also, with tier 5 pending, which we'll find out tonight, will surgery dates be cancelled?
Okay, so the first answer, IBS and diverticulitis don't affect having a bypass. Bypass has no direct, diverticulitis doesn't at all. And IBS, we don't know what the effect of bypass could be on IBS. So I do a lot of patients who have IBS and have bypass. And
I see them. Some patients it improves, some patients it gets worse, but it's all about the dietary advice for IBS and avoiding FODMAP foods. But that's another topic for another time. But yeah.
Which, as a surgeon, I won't say much. I would say, yes, have it. I don't think there's a problem. Tier 5, I think we'll cross the bridge when we come to it. I think government is not going to cancel all private operations anymore. We cannot handle it. The effect of COVID directly is almost as bad as the indirect effect of COVID now. With so many patients having canceled surgery, I think it became such a big problem in the first lockdown. I think surgery will continue in private hospitals, maybe to a slightly lesser extent, but it will continue.
Right. She's got a couple of more questions, but I'm going to ask hers later because there's some other questions that we need to go through. So Caroline, we will come back to you. Right, Tamsin had a question. She said, why do they keep the stomach in place? I know the answer, but this is her question. I think you need to answer it. Why do they keep the stomach in place with a bypass, but remove it with a sleeve?
Interesting question. That's how the operation was constructed. In a sleeve, the aim is to remove ghrelin. That is the main reason. That is why, and make a stomach tight and narrow. That is why you remove it. A bypass is not relying on ghrelin at all. And that is why you leave the stomach behind. Now, you can take that stomach out, but it will increase the risk of surgery. Right. One. And secondly, that stomach is still producing acid that you need.
Absolutely. And then, yeah, and you're still getting all those digestive enzymes and acid that are traveling into the bowel a little bit later on. And so that's why the stomach's kept intact. And also with the sleeve, I mean, you remove 80% of it, but you know, it wouldn't be getting any food. It's not doing anything at all, is it? You can't just staple line, you know.
We did in the past. So 30 years ago, there was an operation by the name of Magenstrasse and Mill, whereby you stapled the top part of the stomach right to the bottom, but you left a bit of opening at the bottom of the sleeve, and the rest of the stomach was connected to it to supply the juices. It started stretching over time. So that is how the sleeve operation was invented. That was an operation known as Magenstrasse and Mill. It was done quite a lot in Leeds till 20 years ago.
Wow. Okay. Right, Tamsin, hope that answered your question. So Natalie, I know you can't drink I think this is a question that I can answer as well. I know you can't drink for 30 minutes after food. So when you've had a bypass or a sleeve, and for patients that have had gastric band, we say don't eat and drink together, but you've got to wait 30 minutes. She says, sometimes I like spicy food, so does Rishi. Is it okay to have a few sips of a drink if she needs it?
I think it should be fine.
Yeah.
What we have to understand is that the drink rule is very important if you start having dumping. But if you're not having any problem with dumping at all, then it is not that hard and fast. I don't know what Van thinks about it.
Right, there's two reasons. There's a couple of reasons why I would say you can have the odd few sips, but don't get into the habit of eating and drinking together. And one of the reasons is, as Mr. Singhal said, that if you eat and drink together, you'll dump. But secondly, you've got to remember, with a small stomach, if you try and eat and drink at the same time, that means your stomach's expanding, it will stretch it over time. So it can't really hold that capacity, and you'll end up regurgitating. So that's why. And also, if you eat and drink together, you're flushing the food out of the stomach patch quickly. And if you flush it out quickly, you're going to get hungry again. So they're the reasons. But a few sips now and again when you're eating spicy food isn't a problem. Yeah. Okay. Okay, so it's about going back to this is Anissa, one of my clients from America. Her question is, what's the facts about stretching your stomach with a sleeve? How do you know? And I'm going to add in, how long does it take to stretch a sleeve?
Well, we have learned over time, patients are different. If you are not going to follow the advice, you can start stretching the sleeve after 3 to 6 months. You can start stretching it as early as 6 months, I think. And how would you find out? Well, you will realize that slowly you are starting to eat more and more, and the satiety is not there. Not stretching the sleeve is all about support and advice. The surgeon's job, and it pains me to say this, but surgery is only 25% of your bariatric journey. The remaining 75% is the support and what you do with it.
Yeah.
A surgeon does exactly the same sleeve with a variance of around 1% in all the patients, but everybody gets a different outcome. So it's not related to the surgeon. It is related to the patient. And
I know, Rishi, that must have been really painful for you to admit that.
Yes. I would hate to admit that you are important, Van. I can't.
No, but I think so. It's like it's about an MDT, isn't it? You've got to do. I mean, I can't do what you do, and I don't think you've got the patience to do what I do. But so that's a man for you, typical man, right? So Jill has a question. How many patients have you had for revisional surgery to make their stomach pouches smaller after a gastric bypass, and how much do they stretch?
After a gastric bypass, I'm referred a lot of patients who need revisional bypass surgery. Now, revisional bypass surgery uniformly has not great outcomes. If somebody does want me to do it, then I will do an extensive workup, and yes, I will revise them. But we have to acknowledge that revising the pouch only may not have great outcomes. The thing you can add to it is distalize or move the bowel further south. That may have slightly better outcomes, but that could be associated with diarrhea, and we will have to accept that. There's the only two mechanisms that a surgeon can change, at least short, small, make the pouch small, which is easy. Well, easy in the grand scheme of things. And you can move the bowel south, which is again, not difficult, but the results won't be great. They may be good, they may be okay, they may be bad, but they won't be great at least.
So what you mean by when you say that you're moving the bowel south, you mean it's causing more malabsorption?
That's correct. That's correct. More diarrhea, more fat malabsorption, more vitamin D loss, more calcium loss, more multivitamin deficiencies. So you'll start seeing things that you see in BPDs.
Right. So it needs lots of support then.
It needs a very, very close work with a dietitian. If you're getting a bypass revised, I think I would advise you to have a dietitian with you at least once a year. At least once a year for the rest of your life.
How often do you revise pouches?
Again, only pouch revisions, I resist doing them because the outcomes are pretty poor.
Right, okay.
If there is a problem with a pouch like reflux or something, or the hockey stick is too long, yes, I can revise them. Only pouch revision for weight loss is just, doesn't work. Doesn't work.
Okay, right. Okay, so this is a question from Lavina. I would like to know from a surgeon's perspective, do all patients put on some weight post-surgery at around 12 to 18 months? And if yes, Why does that happen? Especially considering that the focus is on gaining good habits during those 12 months. So why does the body end up going back up? Why does the weight start to go back up, and how to avoid this regain? And she says she asks this because she's been told by her bariatric team, and I think she's over in Ireland, that it happens to everyone. And she's really curious to know what causes the regain.
Patient will have the same journey. The weight drops, and correct me if I'm wrong, man. Weight drops around 18 months to 2 years, slight gain, and then flattens out again.
Yeah.
The worry is not the slight regain and flattening out. The worry is that it keeps on going up and goes back. So that is where you have to act. Why does a bit increase? Because I think when it levels out, I can't give a very scientifically coherent answer for that. That why does it gain a bit after you've lost your peak weight? What would you say, Van?
I think it's partly to do with, we get a bit comfortable. The surgery is assisting you really well for 6 months, 12 months, maybe 18 months, and just like anything in life, if the support isn't there, and that's when sometimes aftercare sort of starts to run out, all of a sudden the accountability is gone. No one's checking in with you. And so some of your old habits start to come back in if they haven't been managed. And I just think a lot of it is to do with that. And also I think it's partly to do with the set point theory. You're really following all the rules, everything's tight, so you get to your lowest weight, but it's actually not maintainable or sustainable. And that's why I think the weight that starts to shift back up is to get you to that normal set point that you need to be at. And that's a lot more comfortable. But like Rishi said, the concern isn't about like a half a stone weight gain, or maybe even a stone. It's when that weight keeps going up and up and up. And that means that you're not actually working with the surgery itself, and there's something more emotional going on, or you just, the old habits have reappeared, or you've not had any support, which is what happens to a lot of patients that go abroad. So, that's what I believe it is.
Yeah, no, I completely agree with that. Yes.
Yeah, but it is normal to have a slight gain. What that slight gain is going to be for you, it might be 2 kilos, might be 3, it might be a stone, might be a stone and a half. We don't know. It's all relative. Everybody's very different. So that's why I always say, and I know it's difficult for you all, don't compare your weight loss to others if you can. Right. So Victoria's got a question here. If the sleeve has, you can tell everybody, I know one of the things I asked a question in the group was, what are your biggest fears? And it's regain, stretching the stomach. So again, this is a question about stretching the sleeve. If a sleeve has stretched over time since surgery, oh no, we've asked this question about pouch recess. She said, oh, we've done this question. Oh, hang on, I know what the second part of the question was about. Are there guidelines in place that detail the level of aftercare and follow-up consultation you should have post-surgery? I know we have in the NHS.
There are no the guidelines are about how many times you should have a blood test post-operatively. The guidelines are about what kind of supplements you will take. But every hospital, NHS or private, would provide a different level of post-op service. Some would say face-to-face, some would say once every 3 months, others would say 6 months, others would say once yearly. The important thing is that you should have that support, and if you don't have enough support, get extra support and engage with it. It is not the amount of support, it's the quality of support that makes a difference.
No, and I know most NHS hospitals will offer every 3 months you get a 15 to 20 minute call if you're lucky. And that will last for 3 years. I think in the private sector it's slightly different. It's very similar to the NHS. But again, each company and each surgeon will differ with their support. My support is every month because I know you need that accountability, and also to resolve emotional issues. If you leave it for 3 months, we're back to square one by the time we get back to that consult point. And there's no point. You need to just, once you're in there, you just need to crack on with it and get on with it and sort it out. So that's why I do every month, because I feel it works better.
I think if you're not happy with the support you're getting, go and get additional support. Bariatric surgery, you get 1 bite at the cherry. Sometimes if you're lucky, you get 2 bites. So if you don't think you are happy with the support, go and get more support. But try finding ways to make it work.
Absolutely. Absolutely. Right. I can't believe it. We're actually almost on time. So this is the last question, but I will check. I think that is. Gosh, you know what? This is amazing for me and you. We're actually running out of time. So this is Caroline again. This is the lady that is thinking about revisional surgery. So this is her last question. What pain relief is given and when is this discussed? And this is, I'm assuming this is post-surgery.
I would reassure you from pain relief point of view, having done over 200 or 300 revisions and more than 2,000 bariatric procedures, almost all of my patients are walking within 2 hours of surgery. We give you enough pain relief, and I've noticed that the revisional patients actually require less pain relief than more. I won't worry. This is the least of your worries. You will have such good pain relief that you will be able to walk. I can hardly remember any of my revision patients who went up within 2 hours of surgery. So don't worry about that.
I know some of Rishi's patients in the NHS when I used to work with him. When I used to go and see them afterwards or called them, they would say that they were in no pain and they were actually questioning whether Rishi had actually done the surgery. But I think they realised when they started to eat food that the surgery had been done. So yes, don't worry, Caroline, don't worry about pain relief. And then her next question is, what about antiemetics? As previously, I was extremely sick for days following the anaesthetic. So would she need anything like that?
Anesthetic doesn't last in your body for days. It's only 24 hours. So if you were sick for many days, I suspect it was the band, whichever way that was put in. Was it a bit too tight? Was a bit of fluid left in? I don't know. After a bypass, I uniformly see hardly any patients being sick. After sleep, there is a bit more sickness, but even not that much anymore. I think the kind of drugs we are giving now, hardly patients are being sick.
Okay. Well, another reason why some patients feel really nauseous and sick after surgery is when they get home is because of the multivitamin and mineral, especially if they're taking the gold standard Forcival, which your GP can prescribe. So if you're taking that, you must never take it on an empty stomach because it can make you feel really unwell. And you'll think there's a problem with the surgery, but actually it's the actual vitamin and mineral supplement. That's why I always say just take a chewable one, avoid first Forcival for the first month, take it once you started solids. So that would be my advice, Caroline. If you did feel sick last time, it could have been the actual multivitamin and mineral. I think that's all the questions, Rishi. We've gone through them. Have you got anything that you'd like to speak about?
I think let's talk about something related to COVID and bariatric surgery.
Okay.
I'm advising all patients to undergo at least 2 weeks of quarantine preoperatively. I think that is important. Although the government is stipulating that 3 to 5 days is enough, I think nobody really has actual data on what is enough for bariatric patients because bariatric patients are at a higher risk.
Right.
So it's important to quarantine 2 weeks prior to surgery, and that is easy these days because it's in lockdown.
So let's go through the pathway. They would be tested first, then quarantine.
You would talk to somebody in the office, the PCCs, who will guide you through what operation you're having. Then you'll have a consult with the surgeon. Once your date has been decided, 2 weeks prior to that date. So suppose it's the 30th of Jan, 2 weeks prior to it. So that will be the 16th of Jan.
Yeah.
You will start your quarantine. 5 days before the operation, you will go to the hospital to have a COVID test. And if that is negative, then you can proceed with surgery.
And is that the same time when you do your pre-op?
Yes.
Yeah.
Now, in the hospital, most people have been tested. So most surgeons, I get tested every week. Well, that reminds me, I need to get tested in the next couple of days. Yes.
All right. Okay.
Oh, I've forgotten. Yes, I need to get tested tomorrow or day after. So we get tested every couple of weeks.
Okay.
Entire theatre staff is tested every couple of weeks. So that's not a problem. Nurses are tested. I think post-op quarantine is equally important for a couple of weeks, and that is what my latest research that I'm trying to write up these days is showing, that there's an importance of post-op quarantine. Overall, bariatric surgery will continue, I think, but we just have to be careful.
Yeah.
Okay. So that's the only COVID-sensitive part. But what else do we need to discuss, Van?
Well, how busy are you actually at the moment with revisional patients, with surgery itself?
Quite. So you know that I work part-time these days. So
yes.
I spend a couple of months operating in UK, and then I have a couple of months off usually, or 6 weeks off. So as a result, I am reasonably busy when the time I'm here, but I am actually doing much higher numbers of revision surgery than I've ever done. I think most months I would be doing anywhere between 6 and 10 revisional procedures, plus a lot of primary procedures. So we are busy.
Right, okay.
Demand for bariatric surgery is increasing, and especially with the NHS doing even less bariatric surgery than the NHS used to. I mean, NHS was doing not a lot of bariatric surgery, and now it's even less. So I think that's increasing the demand on private bariatric surgery.
How long is the NHS waiting list at the moment?
This is
About 3 years?
Well, from consultation, it's around 2 to 3 years. Yeah.
So, and what are your thoughts? Actually, there was a question here. Actually, I did miss a question, and it was one of Caroline's questions. Sorry, Caroline. It was about surgery abroad. And she said, it's one of our favorite topics. Why is it much cheaper outside the UK for surgery? Now, I'll say one of the reasons why it's cheaper is because there's no aftercare added on. So there's a fee, a 2-year fee of no aftercare added on. So that'll be one of the reasons. But Rishi, please explain why surgery abroad is more affordable.
Let's take any country into example. Let's go with Belgium. Let's say Belgium, okay? If you had surgery in Belgium with Bruno Dillemans, it would be probably more expensive than UK because he's a fantastic surgeon.
Yeah.
And he charges for his expertise, firstly. He will use the best quality instruments and he will not re-sterilize instruments that are disposable. So you pay not just for an operation, but for how the operation is done and who does it for you. The same thing in Belgium. If you go to a surgeon who's not done in many cases, he's not very famous, maybe good, may not be good, and doesn't have a great facility, well, the cost will be less. And it's even less in some other countries because I know that the instruments are being reused that are supposed to be disposable. Surgery is such a thing where I would not make such compromises. I think the aftercare is lacking sometimes, most of the times, and aftercare is very important. I mean, surgery forms 25%, aftercare is 75%, but if you do the surgery incorrectly, or if you have poor surgery in the first place, I think no matter how good your aftercare is, you will struggle. I think. So if you're going abroad, yes, that's fine. You may have your own reasons, but get very good aftercare with that. But if you're open to the idea, then don't go abroad. That's my advice. I have seen a lot of complications. And if you want to go abroad, then go to the top surgeons, not the ones who are advertised on the web. The ones who are actually the top surgeons in that country. And every country has one or two names that stand out. In Germany, there's Professor Rudi Weiner. In Belgium, there is Bruno Dillemans. I mean, these are names that stand out. If you want to go abroad, then have surgery with them.
But you'll probably end up paying more.
Oh, definitely. These surgeons will do off what I charge for surgery, of course.
Right. So what do you think of places like Turkey and the Czech Republic, where you can get, a bypass for a third of the cost of what you would pay here?
There are some very good surgeons I know in Turkey. There are some very, very, very good surgeons I know in Czech Republic. They're great surgeons. But are you going to those surgeons? I doubt those surgeons will reuse laparoscopic instruments. I doubt those surgeons will use poor facilities. I think you get what you pay for.
Yeah, so absolutely.
I can't brand Turkey as a bad place. I know so many great surgeons in Turkey, but I don't think those are the ones that are advertised on the net. The ones advertised on the net are the ones who are different.
Yeah, so if you're going abroad, do your research. There are good surgeons in every country. Compare the prices and weigh up the pros and the cons. But like we say, you come back to the UK, you might get aftercare, a minimal aftercare with whoever you go with, but it will be from a local nutritionist. So it'll be about their food. They may have copied and pasted some information off the internet for you. But, like I said, a lot of the work that I do with you all on a one-to-one is a lot of it is mindset, and that's very difficult to translate into a different language. So do your research if you're thinking about going abroad, and then make sure you've got some support organized as well.
And knowing the best surgeon is not just about who's advertised the most. Please you need to look at their academic credentials, as how much research they are doing, and not just the patient reviews. That is not enough. That is just not enough.
Yeah.
You need to do a lot more deeper than just seeing 5 Google ads from a surgeon to know that they're the. If you type my name, you will see a lot of Google ads or my presence. That doesn't make me a good surgeon at all. There is much more than just looking at advertisements.
Yeah. Right. The other thing I want to talk about actually is smoking and alcohol with
Oh,
surgery. So why didn't you, I mean, I don't,
smoking
hopefully there isn't any smokers in the group, but you just never know. What's your advice about smoking? Because I know it's the same as mine.
smoking is black and white, completely. You cannot smoke before surgery, and you definitely cannot smoke after surgery. If you smoke after surgery, you will end up getting an ulcer. An ulcer in a sleeve will either cause a stricture or a leak, and an ulcer in a bypass will cause a stricture or a leak. Leaks will be life-threatening, strictures will be time-consuming and will destroy your operations. So without going into the detail of how difficult these things are to manage, just don't do them. They will destroy your operations and could end you up on an operating table in a very difficult circumstance when we even have to reverse the bypass.
Yeah.
So dangerous. Preoperative smoking, while smoking will increase the risk of your lung complications during surgery. So I ask my patients, the day I speak to them, I ask them to give up immediately. And taking into account that I'm talking to most patients at least 2 to 3 months before surgery, I ask them to give up immediately. Then drinking, moderation. What is moderation? Well, my moderation is different from Van's moderation. I thought I would bring that in. I say 1 to 10 units. I think
Okay. And how long do you like them to be off alcohol after surgery?
6 to 8 weeks at least.
Yeah. Yeah, that's phew, thank goodness for that. That's what I say. And sometimes I say for patients that have had reflux before surgery, or they have a lot of acid or if they're regurgitating after surgery, I tell them to keep off alcohol for about 3 months if they can.
Yeah.
But the other thing about
3 months is perfect. 3 months is
yeah.
good. Longer is better. Remember, each unit of alcohol has 200 calories. So 10 units a week is 2,000 calories, which is equal to 300 extra calories a day.
Right, so you can tell Mr. Singhal's really good at maths, which is great. But no, and also when you drink after weight loss surgery, the effects of it, you become a lot more sensitive. So really what I'm saying is you become a cheap date after weight loss surgery. You know, the effects are enhanced, so you can't drink very much. But also you need to be mindful, because you might make lots of poor food choices if you drink most evenings. So again, be mindful of that. And also it stimulates your appetite. So that's my advice, just to be mindful. But I never say with alcohol or food that you must stop doing something, because the more I dictate the information, the more you're going to want to do it. So unless if it's life-threatening and it's going to cause a problem, you know, everything in moderation is fine.
No, but
except smoking.
If any patient is drinking more than 10 to 15 units, I ask them to quit completely for now. And then think about restarting 3 to 6 months down the line.
Yeah.
Because at 20 units, moderation is not really, I think 20 is too much. And I don't operate on anybody who's beyond 20. I just ask them to completely stop and then come back to me.
Yeah.
Smoking is black and white, as I've told you.
Great. I think we can leave it there now, Rishi. Hopefully everyone's got some extra knowledge about surgery, what Rishi does, what I do, and we'll look forward to having you again, Rishi, in a few weeks' time.
It's always a pleasure, Van. Always. Thank you.
All right, you take care. Thank you very much. And to the members, I'll see you on Wednesday. Bye.
Bye-bye.